I'll give you the bad news first. The bad news is Prof. Rez is not here. He will be in the future. By that, I don't mean planet Earth, just to be clear. He is on planet Earth, alive and well, but he's not here with us on Zoom today. I can't wait to tell him the story. Um, uh, but but increasingly, Prof. Rez, the big bosses in the world get, they start to wear a suit and tie, and they start to do very, very important things like Prof. Rez is. Um, and so increasingly, we've been using this space to mirror Thursday VMR, where you hear this constant voice accompanied by a junior member of the team who's often doing their first discussion. It's a way of thanking them for what they do and to really impart upon them the ultimate task of CP Solver, which is to try to take care of a patient virtually as best as one can. And this space on Friday represents a parallel process, but for a different kind of person. And there's a whole spectrum of internal involvement with CP solvers. Many people uh, come and put their heads down and do incredible things, but a subset of people really push themselves to the peak of what we do. And one of those people is here with us today. Her name is Seeme. She does not need an introduction, and I've essentially introduced her to you by telling you that she's here to fill Prof. Rez's shoes for uh, uh, out of sheer hard work, dedication, kindness, and all the things you know and love about this space. So I'll hand the mic to you, Seeme, as I try to look for your video on this very old computer. I hope you're still here. Yes, she's still here, finally. For you to say a quick word, and then we'll introduce everybody else who's here.
Hi, Rabih, and hi, everyone. Excited to discuss today. And I just want to say, Rabih, please take good diagnostic care of our patient today. And looking forward to Eugene's case.
I love that. I love that. I don't know how to treat anything, as I mentioned to Jeffrey yesterday, but we can certainly try to figure out what's going on. Um, Making this happen are our beloved Academy members, and there's 3 of them in this space today. So it's an all internal affair. Why don't we start by handing the mic to Shreya, one of our newest Academy members, to introduce herself.
Hi everyone, I'm Shreya Upadhyay. I'm a medical graduate from Nepal, and I'll be scribing today, and I'm so excited for the case.
Amazing. Alrighty, from St. Louis all the way across the world, Lyra is doing teaching points. Lyra, I think you have an update for people.
Yeah, hi everyone. My name is Lyra, and I'm now officially a first-year resident in Russia doing my clinical rotations. Yeah, very happy to be here. Haven't done teaching points in a while. I'm so excited for Seema's discussion.
We're so happy to have you back, Lyra. Yeah. A week has felt like ages, but we're very happy to see you here. Last but not least is our now, I would say, quite experienced case presenter. Eugene is starting to really push the limits of case presentation, if not reaching them. I'm very happy to see you presenting yet another case, and I have to tell you, every single time you do, I know we're in for a treat. So very excited for the learning coming our way, and gratitude even before you start for putting the case together. But let me hand the mic to you. I don't know if you want to share your updates. I got some great news from you, but that may be more personal, so we can keep that for later. But I'm very happy and wanted to acknowledge that.
Yeah, I mean, thank you so much, Dr. Rabih. This very wonderful family. I'm always excited to be here. I'm a physician from Ghana, applying to start in 10-year, hopefully next year. And yeah, this was a case that was seen just on the 28th, very fresh, not too difficult, but packed with a lot of learning. So I'm actually happy to share it with all of us. Yeah.
Wonderful. All right, take it away, my friend.
Sorry, I think I muted. Okay, so the presenting I mean, we have about 4 to 5 aliquots. So I'll just start with the presenting complaint, which is an 81-year-old female, known case of prior ischemic CVA with residual left hemiparesis, was brought in with complaints of productive cough, difficulty breathing, and reduced activity over the past 3 days prior to presentation. and there was acute worsening in the last 12 hours. I would pause here to hear your thoughts.
Oh, an excellent start. Yeah, Seeme, I'm curious, what is flying through your mind?
A very rich post-study quote, and I'm thinking about cough as it can be caused due to signal or a substance, like it can be sometimes due to ACE inhibitors. So definitely see what medication the patient is on, and sometimes it is just due to vagal irritation. So that is something I'm also thinking about, and we have had cases of mediastinal masses contributing to cough. So that is also something I'm thinking about, but also diaphragm, lung, pleura issues should also be considered, and X-ray can help us make more progress for that. And what are your thoughts, Rabih?
Yeah, I'm curious, how does the shortness of breath, Seeme, how does that influence your analysis of the cough?
Probably we have shortness of breath and cough and also hemiparesis. So I'm also thinking about something neurological underlying cause such as stroke or anything like that, but also open to anything related to heart or lungs, such as
Yeah.
the patient has long history of heart failure, or if the patient history of COPD or anything like that. What do you think?
Yeah.
What do you think, Rabih? What is signal and what is noise here? I'm
Mhm.
having difficult time figuring that out.
Yeah, let's try to do this together. So if you sort of identify and try to simplify your task, Seeme, and say a patient says cough and then says shortness of breath. Which of those two things is more morbid?
I mean, I think shortness of breath,
Yeah,
because with cough, we will see what associated symptom we can look for.
right, exactly. So shortness of breath, right? So I think a general principle when you're taking care of patients is to ask yourself, which complaint do you start with? And my general advice is always start with the morbid one. So if you're hearing cough and shortness of breath, cough represents irritation of the lungs, dyspnea represents dysfunction. And so you might ask yourself, instead of doing a deep dive on cough, you might realize that shortness of breath is more morbid. And so you can then ask, how does the presence of cough influence your schema for shortness of breath? What does the cough do? What do you think?
I mean, I think that when we have shortness of breath, we can think about pre-lung causes, lung causes, and then the post-lung causes, that is
Yeah,
heart. So when we link cough with
yes,
shortness of breath, I would think less about the anemia category, that is the pre-lung
good.
with the blood category. So we
100%.
are more left towards the lungs category and the
Well,
heart category. So that's what I'm thinking about. But when inclined
exactly.
more towards lung, I don't want to anchor, but thinking
Exactly.
more about lung with this.
Exactly. Yeah, exactly. See how the beauty of just trying to simplify the problem. I think the major problem with the CP solver schemas, which are extensive and you've studied in detail, is they give you such a long list of things that are possible. But when you're first meeting a patient, if you think about every one of those things, like if you literally opened your cough schema and your dyspnea schema, both of which you know so well, you really are vocalizing what it might be, how difficult it might be to literally apply everything that you've learned because it just gets so overwhelming. So part of the beauty of seeing more and more patients is to realize, well, how do these two things mix together? And do they mix together and the differential diagnosis is the total sum of their parts? Or do they mix together a little bit like oil and water where they start to separate out and they start to reduce things? And I would say that here the overlap of cough and shortness of breath really prioritizes the lungs as the cause of the shortness of breath. And but as you said, the lungs may not be the end of the story. The lungs may reflect a cardiac process that is now spread to the lungs. For example, a pulmonary edema or a large left atrium that is compressing on the bronchus. And so you might ask yourself, Simi, what risk factors does this person have for lung disease? Why would this person have something wrong with her lungs? What do you think?
No, I mean, I think that the patient has a risk of aspiration in this case, given the history of stroke.
Exactly.
And that's what I can think of.
Absolutely superb. Yeah, exactly right. So you see how, like, if you dissect this you realize that how could you skip over, how could you think of anything else except aspiration pneumonitis or pneumonia in this patient? It's one, very common, incredibly common. One of the most common causes of hospitalization and death in this country is this issue. And so I think that whenever this happens, both something that's common and potentially very deadly, it's very hard to overlook it. Of course, there could be many things going on here, but I think that the operating hypothesis is this aspiration related or not? And that can be a whole spectrum of things. So it can be aspiration induced pneumonitis or pneumonia or lung abscess or empyema. There's many things which we can zoom in on. So for me, my mental framework is this aspiration related disease or something else? And given the ease by which we can evaluate aspiration related disease with a stethoscope, listening to the lungs, and imaging, looking at the lungs, we can make a lot of progress very quickly. And I give all of you license to have operating hypotheses if they're both common and deadly. You don't need to lock them in, but it's okay to write a diagnosis in pencil and keep an eraser close by. So whenever you hear this of a patient who has a high aspiration risk, who has cough and shortness of breath acutely, an operating hypothesis of aspiration-related disease is totally plausible. And should we get a negative X-ray or the patient becomes really, really sick where we should be broad, then it's okay to, I think, broaden. So as soon as Eugene presented, I'm like, this is aspiration-related disease until proven otherwise. And we'll see if it's proven otherwise or not. But base rate would say that I would say 80% of a patient like this is going to be on that spectrum, just as a gestalt. All right, Eugene, we're starting off with bread and butter. Where are we going?
Those are very great thoughts. In fact, when you mentioned that the first thought is aspiration, it just took me back to just right after medical school. When I was doing my foundational years, we're having a lot of patients just come in with aspiration pneumonia. And I remember we had to go to town and then explain to people that they didn't have to feed people who had cerebrovascular accidents. Yeah. Okay, so I'll just give you some more data. The history of presenting illness, she was in a usual state of health until 3 days ago when she developed the productive cough with whitish sputum and some level of difficulty breathing. Then over the past 12 hours, her shortness of breath worsened and she became less active. Her family reported that there was white mucus around her lips and obvious respiratory distress. She doesn't have any fever. She's not vomited. There was no diarrhea, no chest pain, no dysuria, no urinary frequency, no hemoptysis, no autopnea, no PND. She had not passed out, no seizures, no incontinence. In the past history is a history of ischemic CVA, which was diagnosed 18 years ago, with residual left hemiparesis. She's hypertensive on dual therapy, type 2 diabetic on metformin. Metformin is just 500 milligrams BD. The drugs are carvedilol 12.5 and lisinopril 10. Did they mention of any antiplatelets or statins? There was no known drug allergies. Family history was unremarkable. She just lived the family. She's been in the wheelchair for some time, but able to participate in self-care. She doesn't smoke, no alcohol use. And this history was taken from the family anyway. On examination, I examined an elderly woman seated in a wheelchair, looking unwell, had some mild pallor, anecteric, and was in obvious distress. There was flaring. Hydration was somehow fair. Temperature was 36.8. Heart rate was 108, was regular, but by the pulse. BP was 133.73. SpO2 was 91% on room air. And the respiratory rate was 25 per minute. Air entry was reduced bilaterally in lower lung zones. There was vesicular breath sounds and there were bibasal crackles. Then cardiovascular was normal, no murmurs, S1 and S2 were ahead. Neurological, the GCS was 15-15, but there was some residual left facial droop with power of 3 out of 5 in the left lower limb and 4 out of 5 in the left upper limb, but 5 out of 5 in the right side. The extremities, there was some mild bipedal pitting edema up to the ankles. There were no abnormalities in the abdomen, no masses palpable or soft, non-tender. We attempted a bedside swallowing test, but it was not very reliable, so I don't want to report on that. I will pause here and then I'll give us some labs and other stuff later.
Excellent. Thank you, Eugene. What a seasoned case presenter. I feel like an attending is telling me about another case, quite honestly. And I'm also have the privilege of discussing somebody with equal skill. Seeme, I think we should start with how you might really feel in real life. So the first task for your future career as an intern is not to figure out what the diagnosis is to try to stratify, is this patient sick or acutely ill or not acutely ill? So what's your sense of the illness severity? Is it high, moderate, low? What do you think?
Rabih, given the hypoxemia this patient
Yeah.
is having and the patient is on wheelchair, so I think immobilization itself is a risk factor for thrombosis or sometimes electrolyte abnormalities. And if the patient is able to carry out the activity, so I am worried about this patient.
Yeah.
And as for, we have some lung findings as well. So, but I'm not sure whether it is just pneumonia or we should be open to embolism or something like heart failure. But we don't have any murmurs. We do have pedal edema, but doesn't look like more of a heart failure situation at this moment. And what do you think, Rami?
Yeah, now that I think all those things, all those thoughts are superb. I think in real life, once you've identified this patient to be seriously sick, you probably have to start treating them before you diagnose them. So I'm curious if you imagine yourself walking into this patient next year, and the first thing you're going to do is probably call your senior because they're tachypnic and hypoxemic. But if your senior is going to be 5 minutes delayed, what do you think you might do to try to stabilize the patient? Just this is not something that anybody in your shoes should know. The whole point of intern year is so you know those things, but now we're going to give you a little bit of a head start. So what reflexively would you be inclined to do to give this patient time so your senior arrives? So you said focus diagnostically, but now we have to focus treatment-wise, unfortunately. What do you think?
Maybe I think that patient has no fever, so patient is afebrile. Then I'll see that what can we do for the heart rate of this patient. We can get an EKG and see if it is sinus
Good.
tachycardia or something more worrisome. And
Right.
then I think a chest X-ray is important at this point, so we can know if it is pulmonary edema or pneumonia or anything like that we are treating. And about the patient has facial droops and signs like that. So I'm not sure if we need an MRI at this point. So that's why I'm thinking about
Good.
this patient. And also I want to ask about any, if the patient has any medication or substance use, because I think it is sometimes just good to just rule out. That's what I'm thinking.
Good. Yeah, so we'll ask the nurse to help with get an EKG. We'll probably order a chest X-ray. We'll think about the neurological status in a moment once we stabilize. What are you inclined to do about the hypoxemia?
Probably I think we should start the patient on oxygen, but also
Yeah.
sometimes patients with hypoxemia and tachycardia might have something obstructive going on as well. So open to that as well.
Yeah, so let's focus on oxygen delivery. I really want this to be like a very valuable to Sue. So when you've started patients on oxygen or seen them start on oxygen, what have you seen them use to start a patient on oxygen?
Probably I'm not sure
Yeah.
of that completely. I think that further examination and getting like an X-ray would be helpful because if the patient has edema, we need to resolve that, or we need to treat the underlying cause as well. So that's what I'm thinking about. I'm not sure how to approach that. Would love to learn from you.
I think the first thing, Simi, that the nurses would do for this patient is to put them on nasal cannula, the first thing. Because of all the abnormalities that you're seeing here, the hypoxemia is probably the most serious. And so we first put patients on nasal cannula to try to see if the nasal cannula alone will increase their oxygen saturation. The nasal cannula is an effective oxygen delivery tool up until around 6 liters, at which it starts to actually reduce its efficacy. Not that it doesn't reduce its efficacy, but the return on investment of more and more oxygen via nasal cannula is reduced. And so at that point, you'll start to see your patients get a mask, some kind of mask, and there are many different kinds of masks. After the masks are exhausted, it becomes a little bit of a difficult situation as to what to do. Because you have two options. You have high flow nasal cannula, which is a way of delivering oxygen through the nose and giving a lot of oxygen to the lungs. And then you have what's called non-invasive positive pressure. So that's BiPAP or CPAP. And the reason that's a branch point is because high flow nasal cannula is the most effective way to give oxygen unless the pressure from the non-invasive positive pressure is of value. So pathophysiologically, Seeme, can you think of a condition where the pressure to give the lungs may help you reverse the underlying process? What do you think?
What was the question again? I didn't get it.
No problem. So when you're trying to help somebody who's hypoxemic, you start with nasal cannula, then you start with a mask. After that, you're going to decide, is this patient going to need a lot of pressure, pushing air into their lungs, or just high oxygen? So BiPAP will allow you to give high levels of oxygen, but will also force the air in. High flow nasal cannula has a little bit of force, but it's mostly actually just giving you oxygen. So you have to try to decide, is this a condition where the patient will develop benefit from the extra pressure or not? So you have to use your knowledge of pathophysiology to understand which conditions cause dyspnea by a pressure-related mechanism. And in those patients, you should give them BiPAP. So what do you think those conditions might be, where the patient benefits from the forced air in?
I think if the patient's diaphragm is not working properly, there's some neuromuscular issues, then we will need extra pressure to help the patient.
Very good.
That's what I can think about, but would love to learn more from you.
The most common reason you need the pressure, Seeme, is heart failure. And the reason for that is now the pulmonary veins are high pressure and the fluid is under pressure. So if you give a patient BiPAP, you push back against that cardiac pressure, allowing a patient with pulmonary edema to breathe much easier very quickly. So in this patient, we'll probably put her on nasal cannula, and based on just the fact that she's only at 91%, she'll probably respond. But if she doesn't, this is why it's really important to ask ourselves, what is our pretest probability of heart failure or something else? Because if we thought she had a high chance of heart failure, we would probably give her BiPAP. If we thought the chance of heart failure was low as a cause of hypoxemia, we would probably give her something else. Just to round out the list of pressure responsive conditions, it's heart failure, neuromuscular weakness, as you said, and then COPD. So here, I think I would probably, as a sense of could she have heart failure or not, I think it's possible, but as you said, the probability isn't very, very high. So I think I would just start with nasal cannula and see where that goes. So yeah, I think next steps, as you said, Seeme, EKG, chest x-ray. If you have the ability, you can do a point of care ultrasound, and the basic labs will allow us to make a lot of progress. All right, Eugene, mic to you, my friend.
Okay, fantastic. So I would give you some labs. Of course, she was put on oxygen and via nasal cannula, and then the oxygen saturation improved. We did some labs, took some samples for full blood counts. We did some ABGs, renal function, EKG. So I'll just mention them. White cells was 12.6, neutrophilic predominant, HB was 10.8, platelets 220. The ABGs was drawn on Ruben. pH was 7.46, PCO2 36, PO2 72, bicarb 25, renal panel urea was 3.6, 8.7 milligrams per deciliters. Creatinine was 1.05 milligrams per deciliters. Electrolyte sodium was 140, potassium 4.5, chloride 106. We had a previous renal panel from 2 months prior. Urea was 3.17 millimoles. That's 7.9 milligrams per deciliters then. Creatinine was 0.66 milligrams per deciliters. Sodium then was 139, potassium 3.88. And RBS was 168. LFTs were not abnormal, they were fine. AST, ALT, ALP. And albumin was just slightly low at 3.0. CRP was 45, was elevated. Procalcitonin was mildly elevated at 0.9. We did troponin I, BMPs. Troponin I was normal, 0.02 nanograms per milliliters. BMP was 210, was just mildly elevated. We also did some D-dimers just to make sure that there was no embolic phenomenon going on. So D-dimers was 1.2. ECG just showed sinus tachycardia, no acute ischemic changes. Let me pause here and then let you discuss these labs and then we continue.
You asked and you received, Seeme. So how are you using this information? Where did your mind start to go?
Well, I'm just happy we did not have to read the EKG today. So I think I'm thinking about WBCs with neutrophilic predominance. So we can think about ischemia, but also we consider pulse under pressure. And the lung might be the focal point here, but I don't want to anchor on that. And we do have elevated ESR, CRP, so definitely some inflammation going on in this patient. And I think albumin was a little low, so I'm thinking whether it is due to decreased intake or increased loss that can be related to GI or kidney as in nephrotic syndrome. So that's what I'm thinking about. And Eugene, urea level, was that normal or was that elevated?
Urea was, the current one had increased from baseline of 7.9, so it had just slightly increased to 8.7.
So I'm also concerned about the increased urea level in this patient that can be caused by liver failure, but that is not the case here. Sometimes we have birth defects, urea cycle defects that can cause it. And Rabih, we have taught us about the ileal conduit causing it as well. So that's what I'm thinking about. Would love to hear your thoughts.
Well, I just want you to know for your own knowledge that I think when Eugene is saying urea, I think he means BUN, blood urea nitrogen. Not. It would be really interesting if this patient were actual urea, but colloquially. So I think, yeah, I don't think we'll have to invoke a ileal conduit today. But I love your analysis of everything else, and I'm really curious to ask you again, to sort of practice for intern year. Has this patient crossed your threshold to give her antibiotics? What do you think about that question?
I mean, I think antibiotics are usually started when the patient has cirrhosis, low neutrophils, or when there is
Yes.
sepsis, and there was one more indication that I forgot.
Yeah.
So I don't think that at this point I'm not so concerned about sepsis going on, but
Right.
we'll have to see if the benefit is more than the risk, then might we start it. What are your thoughts on that, Rami?
Yeah, you're absolutely right. So you should not start empiric treatment on a patient, meaning that you're starting them without a strong sense of what the diagnosis is, unless the patient has those criteria you mentioned, so sepsis, neutropenic fever, decompensated cirrhosis, and rigors. And so the question is, are you now confident enough about a specific condition to treat the patient? So for example, if Eugene said this is an 81-year-old woman who presents with 3 days of dysuria and found to have pyuria and a positive urine culture, you would say, I'm going to start antibiotics because I'm treating not empirically, but I'm treating a very specific infection. And so the question for you is, have you gained enough confidence about a specific infection to treat that infection, not empirically? What do you think about that?
Probably, I think that lung X-ray can help us make
Yes.
progress, because if we are thinking more about aspiration pneumonia, then definitely we'll have to treat this patient for
Good.
that.
So if we just practice your sense, so if your X-ray came back as having an infiltrate, you think your threshold would be met by then to treat her for pneumonia?
Maybe I think getting a blood culture, and if the X-ray shows that, and then neutrophilic leukocytosis, we have
Yeah.
that, and we do have procalcitonin as well. So we have signs of inflammation or infection.
Excellent. Yeah, I agree with you. So now the question for you to ask is the patient too sick to wait for an X-ray? Because if you're in a resource limited setting and the X-ray is going to happen tomorrow, do you think you would wait until tomorrow? Or is your pre-test probability of an X-ray high enough that you would institute treatment now? What do you think?
Maybe I think we can start the treatment now if we're not getting an X-ray till tomorrow.
Yeah, I agree with you. I think this is a really important conversation that I don't think we've had, which is like, how do we diagnose pneumonia? And the diagnosis of pneumonia in principle is very straightforward, but in real life is very difficult. So what is it in principle? In principle, you have to demonstrate an acute infection in the alveolar space. So there are two components, a microbiological component and a localization component. So how do we demonstrate that somebody has an acute infection in their alveolar space? We often do so indirectly because we very rarely sample the alveolar space itself. So we use proxies of those two things. So what proxy do we use for the alveolar space? Our stethoscope, suggesting crackles, X-ray, ultrasound, and CT, visualizing abnormalities in the alveolus. And I said X-ray, ultrasound, and CT in that order because the sensitivity and specificity increases the further you go down that list. So that's the alveolus process: a stethoscope, chest X-ray, ultrasound, and CT scan. The question is, how do we prove that somebody's infected? And the gold standard is microbiological sampling of the alveolus, but we use a lot of indirect measures. And indirect measures start with demonstrating the patient's inflamed. And inflammation can be demonstrated by neutrophilic leukocytosis, fever, so on and so forth. And then trying to find a microbiological culprit. I have some really bad news for you all. Only 40% of patients diagnosed with pneumonia have microbiological proof. And often that microbiological proof is for patients with viral pneumonia, with a positive COVID or a positive influenza. The rate of positive microbiological proof for bacterial pneumonia is probably in the single digits. So if you're listening closely, you'll realize that proving a disease is alveolar is easy. Stethoscope, X-ray, so on and so forth. Proving that that alveolar disease is an acute infection is very difficult. So the major way we make progress is actually counterintuitive, but it's by asking ourselves, what else could be in the alveolar space? And the possibilities are pulmonary edema, lung infarction, and more commonly, irritants. The most common irritant is aspiration, but there are a whole long list of irritants, from radiation exposure to hypersensitivity pneumonitis to vaping-induced lung injury, so many of them. The worst possibility is the alveolar infiltrate is cancer. But that's something we think about down the line. So how do we diagnose pneumonia? The easy part is to prove there's an alveolar disease. The hard part is to prove that the alveolar disease is infectious in nature, and that we only do in a small fraction of patients. So how do we really make progress? Is we are thoughtful about the possibility of irritants and vascular diseases, either pulmonary edema or infarction, and later on, thoughtful about cancers. The way we make real progress on the possibility of infectious alveolar disease is response to treatment. So if a patient improves with antibiotics, we limit the differential diagnosis to pneumonia or spontaneously resolving conditions like irritants. And so here the question to me is, have we reached that threshold? And I would argue the answer is yes. We have an alveolar process as evidenced by Eugene's excellent exam, and we have inflammation. The threshold here is also influenced by the relative illness severity of the patient, which is high. So what else is possible? Vascular issues, pulmonary edema or lung infarction, irritants like aspiration pneumonitis or many other ones, or possibly cancer. But her threshold to see how she responds to treatment has been met. And if she gets worse with treatment, either we have the wrong diagnosis or she has a really severe disease that we have to control. So I would give her antibiotics just like you suggested. I think I was hoping to discuss what kind of antibiotics we'd give her, but I know Eugene has a couple more aliquots, so we can revisit that topic later. All right, Eugene, what do you have next for us?
Okay, so I think it's time to show the X-ray. But like I said, I mean, there were other ancillary labs. Repeated the HbA1c was 7.2. Did urine test, that's urine UA. Was hazy, no blood, trace protein, trace leukocytes, 4 past cells per HPF, 30 epithelial cells. I'll just share my screen to show us the X-ray.
You got away without reading an EKG, but
I have the EKG, but because it was just sinus tachycardia, I didn't want to just put anything there. Could you allow me to share, please?
Of course. Sorry about that. I got too distracted by my ancient computer here. Okay, you should be good now.
Can you see my screen?
Indeed, and your finger, right? Is that you or somebody else?
Yeah, that's my finger, yeah.
All righty. Well, Seeme, what do you think?
Rabih, I think I'm seeing some reticular opacities, bilateral opacities. That's all I can see, and relying on you for the rest of the reading.
Oh my gosh, that was so quick. How did you do that so quickly? Yeah, I'm right there with you. I think the major abnormality is in the right lower lobe. There are some reticular opacities for sure. I'm also a big fan of reading x-rays very quickly and then zooming in. I think the heart border doesn't look too enlarged. There's some aortic calcification. The contour of the trachea is abnormal, but that's likely because the patient's rotated. Yeah, you can see that her neck is twisted and her spine is straight. So yeah, I'm right there with you. I think that yeah, the major abnormality here is exactly what you pointed out. And just keep track of the trachea, because if it's not rotated, then there's a differential diagnosis. Some smaller things, so now going through it systematically, the bones are totally okay. And there's some small bilateral, very small bilateral effusions, but nothing very large. You can see that there's no diaphragmatic crescent on either side. But I think the major abnormality you identified. What was your read, Eugene?
Yeah, I'll just give the radiologist comments. You've done the expert work already. So yeah, so this was we had some bilateral lower zone consolidations. Trachea was central, there was no issue. Also, the middle zone had some consolidations, yeah. We did an abdominopelvic ultrasound, it was normal. Sputum, normal flora. COVID test was negative. Blood cultures after 5 days had no growth. But I want to know if you want any additional test or the diagnosis has already been clinched then.
Seeme, Eugene is asking a question. What do you think? I think it's a fantastic question.
Rabih, I think you knew the diagnosis even from the first telecall. But for me, I think we still need a CT scan to be sure. What are your thoughts on that?
Yeah, and can you just let us live in your tension? So what tension is your brain having that's wanting to know more? What are you trying to clarify? So if a radiologist say, hey, can you please tell me why you're getting the CT scan so I know what I'm looking for, what would you tell them?
I mean, I'm thinking that maybe we can see that if we have any abscess or something like that, or so we can just like, for example, if we have abscess, we will have to cover for anaerobes as well. So I'm just thinking maybe we can get a CT, have a better picture of everything. Or what are your thoughts? Would it be negative, or do we need that?
Yeah, I think that would it be nice to have? Of course. I think a CT scan would be essentially confirmatory of whatever disease process this is. I think we now know, CV, that she has an infiltrate. So if we just zoom in on like what causes an infiltrate, I think irritants and infections are the most common, especially if it's unilateral or multifocal. And then vascular issues, be it venous hypertension or ischemia, are second. And the third is cancer. So if you had to rate your suspicion, is your suspicion of cancer very high or manageable right now? What do you think?
I think we don't have any weight
Yeah.
loss, we don't have any smoking history, so that's lower on my differentials.
Exactly. So let's keep going, okay? So what's your sense of a lung infarction? Is it manageable right now or is it extremely high?
Well, a patient has risk factors of immobilization and patient has one stroke, so maybe there is likelihood of having another one. Also, patient is above 60, so that is definitely something we should
Right.
consider.
Very good. It's way more plausible than cancer, right? He's immobile. So could this be a pulmonary embolism with infarction? Absolutely. It's interesting how we factor in that her D-dimer was underwhelming, and I have to be careful. So that's still a possibility. Do you think, so the other vascular hypothesis, pulmonary edema. What's your calculus about the probability of pulmonary edema?
Pulmonary edema, Rabih, I think it is possible. We have crackles as well, but we just saw reticular opacities. I'm not sure about that, but worth considering, I think, but less likely than infarct or infection for me.
Yeah, agreed. So now the question for you is, are you willing to wait 2 or 3 days? Or are these hypotheses so strong that you cannot wait now? Because, like I told you, we don't diagnose pneumonia now. We diagnose presumed pneumonia now, and then 3 days later, if she's better, we either had an infection or a transient irritant. So the question for you isn't to write your diagnosis of pneumonia in pen, sorry. It's, are you willing to use now as your next step trial of antibiotics? So the question for you is, can you sleep on this case for 2 or 3 days with antibiotics, knowing that if she gets really worse, right away you'll scan her for PE? That's the question. So what's your gut sense? You're going to have a whole career to fine tune this sense, but where are you starting now?
Well, I think we can start antibiotic, but also check for pulmonary embolism because if it is present, then the mortality would be very high. So we should, I think, do that.
Yeah. I think that you will find, Simi, in your experience, part of intern year to be potentially frustrating because many different attendings do different things. But that's because there's a lot of uncertainty here. I will tell you that I don't see an urgency to diagnose this now. But if you told me this patient was intubated, we would have put her in the CT scanner 30 minutes ago. If you tell me that she's on no oxygen, I would say, what's the rush? And for me, nasal cannula definitely falls way closer to no oxygen than intubation. And so if she were on a face mask, so illness severity drives the velocity at which you pursue diagnostic hypotheses. And the diagnostic hypotheses we've already outlined here: irritant, infection, pulmonary edema, infarction, cancer. That's the journey. How far do you go? I think that the illness severity here is not high enough. Why? Because there are too many patients like her in the world that if we ordered CT scans on this exact same scenario, patients with other CT requiring conditions would suffer by proxy, and the cumulative radiation exposure from all that effect might be consequential. So I think I would try antibiotics, but I think it would be a mistake to say she has pneumonia for sure. So both strategies are defensible. It depends on how you set it up in your mind, and it also depends on your experience. The more and more experience you have, the more and more comfortable you are letting people wait to have clarity. So I would probably just give her antibiotics and see how she does. Yeah, what did you do, Eugene?
Yeah, so at this point, not just me, it was a team. And I'm actually excited that the way you were discussing it was just how one of our team leads just came up with different hypotheses, whether we should do a CTP or not. But this case just tells me much about how approaching an older person, not having a strong flavor for things, yet you need to try to be thorough to make sure that you've covered every area. So we still went ahead, we did a CTPA because this patient has multiple risk factors. Has been immobilized for a long time, it's a stroke, previous stroke. We don't know whether they were even on some antiplatelets or taking any kind of antithrombotics to prevent any form of clots formation. So we did a CTP. However, it showed no intraluminal filling defects in the pulmonary arteries. It gave us a picture of the lungs, and we saw bilateral dependent consolidations with air bronchograms. So the diagnosis was clinched right from the start, from the history, HPI. We already picked out that this patient could have a pneumonia. And yes, the antibiotics were started even before we got culture results and flora sputum results, because the chest X-ray was suggestive. And stuff that I've learned from this case right from the start, this patient's temperature was 36.8. I saw in the chat people mentioning that, oh, there's no fever, so I'm not going to be bothered. But the kill suffer for this patient, of course, is just one, with respiratory rate. We don't have anything pointing towards sepsis. However, I think with the IDSA criteria, if you're going with a CAP 65, though, you wouldn't really call this severe pneumonia. But if you are just looking at the functionality, the fact that it's bilateral lower lobes, she's older, more than 65 years, you could think that this is functionally severe. So it was right that we started oxygen therapy, and then we also went ahead to do the antibiotics. Of course, there was a mild AKI, and that was in the picture, but that could be subjected to her 6-day. So yeah, the fact that this patient started off with an amount of fever, and we can point it out. So I mean, I learned a very fancy word, immunosenescence. That is, older patients actually have that kind of immunosenescence, and also the hypothalamic pituitary axis is not able to mount the fever. So there's a possibility that they may not start picking. But one thing you need to learn from an older person is their functional decline. This patient's activity level went down. So if you want to see whether this patient is actually sick and it's actually not in the form of just a higher body temperature, you can actually look at the functional decline to make sense out of it and say, okay, yeah, this patient is actually sick, needs hospitalization, needs attention so that they don't completely dip. And then many of the other things that were shared, we could see a little bit of flavor. Could this be P because of the tachycardia? Could this be a heart failure? We had a little bit of elevated BNP. And so this is just a reminder. I mean, as bread and butter as it is, it's a reminder for us to try to be thorough, raise our antennas right from the start, and then be able to tackle the case head on to help. So the patient received some levofloxacin and then azithromycin because we didn't really know what organisms were happening in there. And I'm sure if we had done, like Dr. Rabih would say, if you go to the microscopic level, I'm sure we would have found some organisms. but with the cultures, and I'm glad you actually said that, because I didn't know that it's actually difficult to identify an organism when it just comes to pneumonia. So the chest X-ray is one reliable tool to actually go with. So yeah, this is what I learned from this case, and sorry for boring you with a long speech.
This is the first time in 5 years, Eugene, actually the second time in 5 years that anybody has presented a case of pneumonia. It's one of the most common diagnoses requiring admission. So boring is not at all. This is the rarest of the rare. This is actually more rare than HLH on VMR. So thank you so much for a really, really fun session. Now you owe me a CT scan because I saved mine, so I get to use it whenever I want in the future. I hope to incentivize all of you to consider being part of this team and this family, in large part because we're going to have an academy session tomorrow, and I was trying to decide what that session will be, but I think it's fundamentally clear that we all will hang out internally and talk about community-acquired pneumonia. And I just wanted to share a page with you all in case you have no idea what I'm talking about. But if you want to grow up to be like Seeme, you should check out this page. The link is right here. And scroll down and learn a little bit more. Actually, this text is authored by Seeme and the current voice, the upcoming voice you're about to hear. And check it out. I'd love to have you. There's a very, very simple formula to being part of this team. It's to just show up here and present your cases and do what Eugene just did and what Seeme just did. Although don't worry, you don't have to start off by doing what Seeme just did. We try to help support you in doing that. So that is that for me. Seeme, I'm curious what your thoughts and reflections are.
Rabih, I just love the discussion, and I just love that how now today we just didn't only talk about diagnostically about the patient, but how to treat the patient and how to approach the treatment. And I loved how Eugene presented a case of pneumonia in such a interesting way. So very thankful for it. And I just want to share with everyone that I have 2 notebooks from Rabih sessions in the academy. And you can also join us by just presenting a case. And we love everyone's thoughts and having everyone join us.
Oh my gosh, 2 notebooks. That's incredible. That's a lot of learning, my friend. Lyra, I am so sorry to say that I have to be on rounds in 2 minutes, and it takes 3 minutes to get there. So Seeme, I've made you the host, and Lyra, I'm very, very excited to check out your teaching points afterwards. I love the purple line in yellow, and at the bottom, the purple line at the bottom. I think I'm glad you caught it. It's a really important one for us. Thank you again, Eugene, and have a great time, everybody, in the next few minutes, and look forward to see you next time.
Yeah, thank you all for this amazing session, and thank you, Eugene, so much for bringing this bread and butter case, because For me, the simplest diagnoses are usually the hardest ones because there is so much fine-tuning in our approach to do in the future. So thank you so much. Yeah, we started off, I think, with a very interesting thing with shortness of breath, with the notion that shortness of breath is not really an important symptom to build the differential, but it also a really important variable that can be helpful to fine-tune our approach to different symptoms, like cough, for example, that by itself would indicate just irritation of the lungs. So it basically translates to discomfort. But when the shortness of breath is present, we translate that to the dysfunction of the lungs and narrow down our differential diagnosis when we hear that. And also we can fine tune our localization of the problem here using shortness of breath. So presence of cough and shortness of breath localized us to the lungs, but also reminded us to keep in mind the heart as a possible cause of secondary heart lung problem. And we also entertain the possibility of the primary lung problem, especially since this patient has in the history CVA accident. So the patient was at high risk of aspiration, and in such cases, this lung problem is aspiration-related disease until proven otherwise. And when we see a patient with respiratory distress, we really need to prioritize management over diagnostic approach. And here, the primary thing that we would do would be studying an oxygen. Here we have a few ways to do that, like nasal cannula, mask delivery, high flow nasal cannula, and non-invasive positive pressure ventilation. And all of those methods has different purposes and different limitations. So it's really important, at least when we decide in between high flow nasal cannula and positive pressure non-invasive ventilation, in the end of this chain, we need to choose non-invasive positive pressure ventilation in heart failure, neuromuscular weakness, and COPD cases. And when we finally localized the problem to the lungs and understood that it was inflammatory, we started talking about pneumonia diagnosis, and then we also approached the antibiotics that we would start in these situations. So when we consider the diagnosis of pneumonia, we basically mean that pneumonia is an acute infection in the alveolar space. So there are two important variables here. First is localization, and the second is etiology. And if localization is quite easy, we can use physical exam findings and different imaging techniques to localize us to the alveolar process. The proving of the infectious etiology is quite tricky. And here we can look at the non-specific inflammatory labs like CRP, for example, but also we need to pursue a microbiological search for the agent that is serving as a cause of this infectious process. But it can be really hard and positive only in 40% of cases. So the practical approach here would be use response to treatment as a proxy to differentiate different processes that can happen in alveolar space. And when we use that, it basically means that we need to wait, and sometimes the waiting is really beneficial, although it may seem hard to do than doing a CT scan on the second day. So here we need to really see the patient as a whole picture, not just the symptom and not just one disease, and also understand that the illness severity that we're looking for will drive the velocity of our pursuit for diagnostic hypothesis. And I think this was a really, really great session. Thanks everyone for that.
Thank you, Lira, for the wonderful teaching points. And I loved how you added different colors so that we can see the important things differently. And thank you so much, everyone, for joining us. Have a great rest of your day. Bye.